This is respiratory physiology, and in this session I'm going to talk about intrapleural and intrathoracic pressures, static and dynamic compliance, the compliance of the chest wall and the lungs, and compliance curves that you can generate for spontaneous ventilation and during intermittent positive pressure ventilation. All this will lead on to further discussion about the work of breathing. We're also going to cover ventilation and perfusion, distribution and matching. So we'll talk about West zones, the physiology of normal ventilation perfusion ratios, which I'll from now on call VQ ratios, the pathophysiology of the VQ mismatch. We'll also talk about shunt, other areas where you generate physiological shunt, and finish off with the shunt equation. So, compliance. The lung is an elastic structure, so compliance is a measure of how elastic the structure is. The thing to remember is that the more compliant a structure is, the easier it is to stretch. So a high compliance is good in terms of how much effort you need to make to stretch the object. Compliance is measured by the change in lung volume over the change in transmural pressure across the lung. The units usually use the typical medical units, which is mils per centimetre of water, or mils per kilopascal, or litre per kilopascal, and you need to be careful that you know which units you're using. These can quite easily be converted from one to the other, but you're going to get some very silly answers if you don't remember to do that. Before considering the actual mathematics of lung compliance, we need to consider what is the actual reason for the lung's elastic recoil. The elastic recoil of the lung is essentially due to two reasons. One is fairly obvious, and that is that the structure, the underlying structure of the lung is elastic. So as it is stretched, it tends to want to come back to where it was before. But the second, and in many cases, and for pathophysiological reasons, more important cause of the elastic recoil of the lung is the fluid lining of the alveoli. This is an aqueous lining, and so it generates a surface tension. It's extremely thin, and the surface area of the alveoli is very large, so the tension generated can be very high. The fluid surface also includes a phospholipid called surfactant. Surfactant has a hydrophobic part of its structure and a hydrophilic part, and it forms a monomolecular layer on the surface of the water, and it disrupts the hydrogen bonds between the water molecules and therefore lessens surface tension. The beauty of surfactant is as alveolar volume changes, the surfactant stays on the surface of the fluid layer, and so it gets closer together. And so the tendency for the surface tension to cause an accelerating decrease in volume, in other words, an increased elasticity as volume falls, as is demonstrated by the law of Laplace, then this is lessened by the fact that the surfactant molecules are getting closer together on the surface of the alveolus, and therefore causing more disruption of the hydrogen bonds, and therefore lessening surface tension as the volume of the alveolus decreases. So this prevents ongoing alveolar collapse, provided you have normal amounts of surfactant present. There are two types of compliance considered in medicine regarding the lung. That's static and dynamic compliance. Static compliance is greater than dynamic compliance, and that is because static compliance is measured when the lung is stationary, whereas dynamic compliance is measured during normal breathing. All elastic bodies demonstrate a phenomenon called hysteresis, and this is where the value of a physical property lags behind the changes in the effect that are causing it. Dynamic compliance is measured during normal breathing, and static compliance is measured with the lung volume held at rest for as long as practical. This means that because of hysteresis, static compliance will have a higher value than dynamic compliance, because the hysteresis will have caught up, if you like to consider it like that, with the change in pressure that's causing the change in lung volume. During normal breathing, there's no pause between inspiration and expiration, so the volume change hasn't caught up with the pressure change that's causing it. Compliance can only be measured at the beginning and end of a breath, and therefore during this dynamic situation, the compliance will appear less than if the lung is held static at a particular volume. The compliance curve has a sigmoid shape if you're considering the expansion of the whole lung. Pressure change, which is causing the change in volume, goes on the x-axis, and lung volume change goes on the y-axis. You'll notice that the lung volume doesn't go down to 0 because there's always a residual volume below which air cannot be expired. Initially, the lung is quite difficult to expand, so it has a low compliance, so the compliance curve is relatively flat. It then comes on to its optimum point of expansion where it's easiest and the curve becomes steeper, and then as the lung becomes fully expanded, obviously it becomes more and more difficult to stretch up, so the curve flattens out. The blue part of this curve is inspiration and the red part of the curve is expiration, and it's showing the phenomenon of hysteresis. What the arrows are showing are the compliance of different parts of the lung in an upright individual. And because of gravity, the bottom of the lung is a little bit compressed, so it's further down the compliance curve than the upper part of the lung, which is a little bit stretched up. But the key thing to notice that in the normal functioning lung, it's operating on the steep part of the compliance curve. In other words, where compliance is high, and so the lung is easiest to expand. Compliance can also be looked at as on a single breath, where starting at an intrapleural pressure, a subatmospheric pressure that's normal of about -4 centimetres of water, and then as the breath is taken in, it will drop by a couple of centimetres of water to say about -6, and you can see the hysteresis curve operating there, and then the expiration curve is just going back to where it started, and the total tidal volume is shown on the left of about half a litre. A dotted line joining the beginning and end of that curve, the slope of that is the dynamic compliance. Now, the compliance of any system can be considered in terms of structures that are either in parallel or in series. An obvious example of two compliance structures that are in parallel are the left and the right lung. At the carina, the trachea divides into the two main bronchi, and so the two lungs are expanded separately. In order to work out the total compliance of a system in parallel, you simply add the compliance of the two individual units together. The easy way to remember this is that the compliance is going to get larger if structures are in parallel because you've got more elastic structure into which to put your gas, so it's going to be easier to expand, so the number has to get bigger. The physiological example of a compliance in series from the respiratory point of view are the lungs and the chest wall. They lie one on top of the other, so when you're expanding one, you've also got to expand the other if you are artificially ventilating the patient. And that's a very important point to remember, because when somebody is breathing spontaneously, it's the chest wall, by which I mean the ribs, the intercostal muscles and the diaphragm, that are generating the power to expand the lungs, and they are not therefore part of what is trying to be stretched up. So they're not part of compliance in normal spontaneous breathing. But when you artificially ventilate someone with intermittent positive pressure ventilation, then you have to move the lung and the chest wall. So essentially you've got a system that is in series, and in order to calculate the total compliance of the lung and the chest wall together, you have to add up the reciprocals. That means that the compliance gets smaller when you turn the equation the other way up to work out what the total compliance is. The reciprocal of the compliance, by the way, is called the elastance, and you may come across that term being used sometimes. I want to move on now as to how compliance is actually measured. I want to talk about pulmonary compliance in a conscious subject, which I've already touched upon when I'm talking about spontaneous ventilation, and total pulmonary and chest wall compliance in a patient on intermittent positive pressure ventilation. In order to measure compliance in a conscious, spontaneously ventilating patient, you have to get some sort of measure of intrapleural pressure, because that is the force that's generating the expansion of the lung. Now, it's too invasive to start sticking needles into people's chests in order to measure the actual pressure inside the pleura. So the standard way of doing it is to locate a partially inflated balloon in the esophagus with connected to a pressure transducer, usually coming out through the nose, because the patient's going to have to breathe through a spirometer attached to their mouth. The balloon of the pressure monitor is located at about mid-esophageal level behind the heart, and this is taken to give an approximate value for the average intrapleural pressure. It's important that the patient's upright, of course, if you're measuring compliance in this fashion, because otherwise the weight of the heart will press on the balloon and will give you a false reading. At the same time, in order to measure volume change, because obviously you have to measure volume change for a given pressure change, the patient breathes through a spirometer in order to generate that part of the signal. Now, the dynamic compliance in conscious spontaneous ventilation is about 2 to 3 litres per kilopascal. Otherwise, can be converted to 200 to 300 mils per centimetre of water. Under a general anaesthetic with artificial ventilation, with intermittent positive pressure ventilation, it's approximately half of that, usually somewhere around 1.5 litres per kilopascal, or 150 mils per centimetre of water. And the reason for that is, I've already talked about, is because you're having to move the chest wall as well as the lung, so the compliance is roughly halved. Static lung compliance, if it's measured by pausing the breath for a wee while at the end of breathing, will be about 10% higher. Chest wall compliance changes, but under a muscle relaxant, under a general anaesthetic, the compliance of the chest wall itself is about 2 litres per kilopascal. So going back to the normal compliance curve that we looked at earlier, you'll see here that the various parts of the lung in an upright subject are on the steepest and optimum part of the compliance curve. But we need to start considering how changes occur during both anaesthesia and pathological conditions. If we consider the stiff lung first, then what happens, and what you need to be able to do, is to draw a graph of how compliance changes from normal. Normal compliance shows you a nice steep curve with a large lung volume change for a given transpulmonary pressure. Transpulmonary pressure meaning the difference between the pressure in the alveoli and the pressure in the pleura. But if the lungs get stiffer, then the lung volume change is going to be smaller for any given transpulmonary pressure change, and that's going to result in a flatter curve, as shown here. We could also look at how changes in lung volume are going to affect compliance. The other thing we need to consider is what happens to lung compliance under general anaesthesia. And as I hope you well realise, functional residual capacity decreases on induction of anaesthetic. This is a direct effect of the anaesthetic. It's not, interestingly, actually a muscle relaxant effect, because when you give a neuromuscular blocker, the compliance of the lung doesn't change much more. The cause of the decrease in functional residual capacity is essentially just the diaphragm moving up into the chest in an otherwise unconscious patient with a decrease in muscle tone. So if we look at the graph here showing the compliance at point B on the line, shows you a nice steep curve, so a good high volume change for a relatively small pressure change. If functional residual capacity falls, and it's a bit exaggerated in this diagram, but if it falls as low as point A, you can see the curve is very flat. And for the same pressure change shown on the diagram, you're going to get a much smaller volume change. Or conversely, if you want to achieve the same tidal volume, you're going to have to generate a larger intrapleural pressure. You're going to have to work harder if you're spontaneously breathing. This can be partially corrected by adding a little bit of positive end expiratory pressure to bring the FRC back up towards normal and bring the curve back up to point B. And that's the logic of using PEEP during anaesthesia in an otherwise normal patient. Although you do need to be careful that you don't overexpand the lung. For instance, if there's expiratory obstruction, an air trapping and a gradual build-up of volume of the lungs, then the curve's more likely to move up to point C, where not only are you in danger of over-distending the lung and possibly causing barotrauma, but also the work of breathing is going to get higher as well. So there's an optimum point where the compliance of the lung is best, and that's the point around normal FRC. Having considered compliance, we now can come on to talk about the work of breathing, which is an important consideration because, of course, during spontaneous ventilation, this is the work that the body has to generate to move air in and out. First of all, I want to consider what the scientific definition of work is, what work is done during breathing, what is that work overcoming, and during what part of normal respiration is the work done. How all this then relates to the compliance curve and what happens in the abnormal lung. Work is the product of force times the distance travelled in the direction of that force. But if you multiply the distance times the area and divide force by area, you have exactly the same expression, but you've got different units, because force divided by area is pressure, and distance travelled times area is the change in volume. So work can also be expressed as pressure times change in volume. Now, the work done during breathing is overcoming the elastic recoil of the lungs in order to expand them up, and the friction of gas flow and the friction of tissue movement, although that latter one is quite small. Normally, the work of breathing is done entirely during inspiration. It's abnormal to have active expiration, which is an entirely passive process relying upon the elastic recoil built up within the lung during inspiration. And how is all this related to the compliance curve? Well, it's all about the area underneath the curve. You'll remember this diagram from earlier, which is a simple single breath compliance curve showing inspiration and expiration. And removing the hysteresis part of the curves, you see we get a straight line which simply generates the total compliance of the lung during that particular breath. The area shown by this triangle is the work required to overcome the elastic recoil. And it's a triangle, so its area is half the base times its height. In other words, it's the average change in pressure, change in volume. If the lung is less compliant, the curve will be flatter, so the area of the triangle will increase, thus representing the increased amount of work required to take a single breath. We've now put back in the hysteresis curve for inspiration, and this generates a new area, and the area within that part of the curve is the extra work being done during inspiration to overcome the frictional resistance, which, as I've already mentioned, is mainly due to the gas flow, but also a little bit of tissue friction as well. If we now put back on the hysteresis curve for the expiration, the shaded area there within the yellow triangle is the work being recouped, if you like, to consider it, by passive recoil of the lung during expiration. And again, it's the work required to overcome the friction. That was a normal breath in a normal lung. If somebody's got obstructive lung disease, what happens, as you'll see in this diagram, is that the hysteresis curve for the expiration moves right outside the triangle of the work generated during inspiration. And therefore there's not enough stored work there's not enough elastic recoil in order to enable the patient to breathe out. They therefore have to indulge in active expiration using the active muscles of expiration, which aren't evolutionarily designed for that, but that's basically the shoulder girdle, so the arms will be anchored, and also the abdominal muscles forcing the diaphragm up. One of the most amazing physiological adaptations of all mammals, really, is how respiratory frequency is adapted to find the point of lowest total amount of work. Now, you remember from what I was just saying is that the work of breathing consists of work against the elastic recoil of the lung and then work against the frictional airflow of the gas. If we look at a normal combination of these two, you see the work done for airflow increases more or less linearly as respiratory rate goes up because you're reversing the airflow more often. Whereas the work against elastic recoil decreases as respiratory frequency goes up. And the curve at the top is the sum of the two curves shown underneath. And it reaches a minimum. And that is the point at which most people will breathe under normal circumstances. However, if somebody has stiffer lungs, in other words, has increased elastic resistance, what happens is that the work done against elasticity, the curve shifts upwards. Now, the total amount of work of breathing will shift upwards as well, but there'll still be a vaguely U-shaped curve. But what will have happened, because elastic work decreases as frequency goes up, the optimum respiratory rate goes up. And you'll see that patients with stiff lungs tend to have a high respiratory rate. On the other hand, if there's obstruction to airflow, so the work of breathing against airflow resistance has gone up, then the curve gets steeper and the optimum respiratory rate actually falls below normal. And in general, aside from very anxious people with bronchospasm tend to breathe more slowly to find their optimum work rate. So, we've talked about compliance in the work of breathing. We've discussed intrapleural and intrathoracic pressures, static and dynamic compliance, the compliance of the chest walls and the lungs, and how you add these together, the compliance curves for spontaneous ventilation and artificial ventilation, and the work of breathing. I'm now going to go on to talk about ventilation, perfusion, and VQ matching. So, ventilation and perfusion and its matching. Essentially, the blood goes round and round and the gas goes in and out. And this is a source of inefficiency when you're trying to take up oxygen into the blood. But it's what mammals are lumbered with, so it's what we have to work with. And what I want to consider in this part of the talk is the factors that affect ventilation of the lung and how it's distributed, the factors that affect perfusion of the lung and how that's distributed, and then how these two are matched optimally under normal circumstances, and then some of the pathophysiological processes that take place when these are abnormal. This is affected by posture and gravity, the structure and branching of the various tubes within the airway, the posture of the patient, the speed at which different parts of the lung fill due to resistance of gas flow or the stiffness of those particular compartments. In terms of perfusion, we also need to consider posture and gravity and the structure and branching, and that it's a low pressure system pumping a relatively heavy substance around, that being blood, compared with the heaviness of the gas that's being moved during tidal ventilation. So this is going to be fundamentally affected by pressures inside the alveoli and the posture of the patient, and generates the West zones that I'm sure you've all heard about. And also the distribution of ventilation is going to be affected by how hypoxic different areas of the lung are, because perfusion going to areas of the lung that are hypoxic is wasted. So there is this physiological adaptation called hypoxic pulmonary vasoconstriction, which is specifically designed to steer perfusion away from areas of the lung that are not oxygenated. So, if we consider posture and gravity, gravity overall is only about 25% of the story, but if you look at something as simple as a ventilation perfusion scan of the lung, now this is looking at the whole thickness of the lung, and that varies as you go up and down, but looking at the ventilation aspect of a VQ scan, this is where the patient takes a breath of gas with a bit of radioactive xenon in it, which emits gamma rays, and the density of the emission is measured on a gamma camera in front of the patient's chest. And so how dark the area is shows how much it's perfused. And you can see on the ventilation component of a VQ scan that there's more ventilation lower down the lung than there is higher up. In order to get a perfusion scan, you take the same radioactive xenon and you dissolve it in the blood and inject it as a bolus in the vein. And as it reaches the pulmonary circulation, it will diffuse out into the alveoli and therefore giving a measure of the distribution of the perfusion. Looking at the left lung in this diagram, you'll see that the perfusion is also increased lower down the lung. The lung is darker than the higher areas of the lung, and this is simply a gravitational effect. If you look at the right lung, you'll see that there's an obvious defect because this is a typical VQ scan of somebody who's had a moderately sized pulmonary embolus that has cut off the circulation to the outer aspect of the right lower zone of the lung. But gravity is only about 25% of the story that we're talking about. What affects the distribution of ventilation and perfusion within the lung much more is the structure and branching of the various tubes down which these processes occur. The airways do not branch evenly and they're not the same diameter when they do branch. So ventilation will preferentially go down the wider bore of two branches, and the branch that comes off at less of an angle will also receive more ventilation, and this effect can be quite large. Also important in the way that ventilation is distributed is the rate at which different alveolar compartments fill, and they have a time constant. The lung volume of the lung as a whole above functional residual capacity during a breath can be calculated at each time during breathing from the exponential equation shown here, which is Pi is the inspired pressure times the total compliance of the lung times an exponential filling expression, which is 1 minus e to the minus t over the compliance times the resistance. The compliance times the resistance is the time constant of lung inflation. That means that 63% of the final volume is going to be achieved in one time constant. Now you'll see that the compliance features both in the time constant and at the front of the equation, so this will also determine the ultimate volume of the lung for a given inspiratory pressure. But the same considerations also apply regionally within the lung to small compartments, if you want to consider them like that, where each is going to have a different time constant. Any increase in compliance or resistance in an individual area of a lung will increase the time constant, and therefore it will take longer to fill during a given breath. Compliance also determines the ultimate volume change of any one compartment of the lung, just like it does for the whole of the lung. So the speed of volume change is determined by resistance, and the total volume that that compartment of the lung is going to reach is determined by its compliance. An increase in resistance will cause slower filling to the same volume. A decrease in compliance will cause filling to a lower volume for the same respiratory pressure. If resistance is unchanged, filling will be quicker because of the lower volume to which the lung is being filled. Now, under anaesthesia, spontaneous ventilation is mainly abdominal, which is different to a conscious patient, where in the upright position, spontaneous ventilation is usually generated by intercostal movement. Also, when you ventilate a patient, this changes again, and intermittent positive pressure ventilation is mainly achieved by ribcage movement rather than diaphragm and abdominal movement. But the functional effect of this is minimal, and the indices of gas exchange efficiency don't change very much between spontaneous ventilation and intermittent positive pressure ventilation. In other words, dead space and shunt remain roughly the same. So the other exponential process, which is really very important to consider during induction and emergence from anaesthesia and during pre-oxygenation, is the wash-in and wash-out of gases themselves when what the subject is breathing changes. It's an exponential process moving towards an equilibrium. which it never quite reaches in the case of oxygen, for example, because oxygen is being continuously consumed. So it can't reach an equilibrium within the lung. But nitrogen washout from the lungs is an exponential process, and nitrogen is in equilibrium because it's not being consumed or excreted. Similarly, helium wash-in is exponential when breathing a heliox mixture, and this is the basis, you'll recall, from how functional residual capacity or residual volume could be measured within the lung. The time constant for the process of washing of gases, if you consider the lung as a whole, is going to be equal to the functional residual capacity divided by the alveolar ventilation. For example, if the functional residual capacity is 3 litres and the alveolar ventilation is 6 litres, then the time constant would be 30 seconds. But this is theoretical. The process, if that was true, pre-oxygenation will be 63% complete in 30 seconds. But the time constant for the whole lung does not reflect the true setting, because the variation in regional ventilation relative to functional volume and the compliance and the resistance that we've already talked about during the actual wash-in and wash-out of ventilation. In practice, if you're going to completely pre-oxygenate somebody to an alveolar nitrogen of, say, less than 2.5%, that's going to take about 7 minutes in a normal lung. And it's going to be much slower if there's maldistribution of ventilation, such as in patients with severe COPD. In fact, you can use the rate of achievement of helium equilibrium concentration as a measure of how badly distributed lung ventilation is. And then you can use the final concentration of helium to give you a measure of the lung volumes. Pre-oxygenation can be speeded up by increasing alveolar ventilation, and this is the basis of using vital capacity breaths as part of the process of pre-oxygenation. The final thing I want to consider under the distribution of ventilation is the alveolar plateau that is seen on the capnograph, because this is an example sometimes of demonstrating the different time constants within the lung. If ventilation is badly distributed within the lung, the slow compartments in the lung are going to fill slowly and empty slowly, and therefore they're relatively underventilated. If an area of the lung is underventilated, it's going to have a high CO2. On the other hand, a part of the lung which has a fast time constant is going to be relatively overventilated. It's going to fill and empty more quickly, and it's going to have a relatively low CO2. What this means is if, for example, there's bronchospasm, which is never a homogeneous condition, but it varies throughout the whole of the lung, there's going to be parts of the lung that fill and empty slowly, which have a relatively high CO2, and there's going to be parts of the lung that fill and empty quickly, which have a relatively low CO2. These latter are the first compartments that are going to empty, and you're going to see on the capnograph when you're monitoring it. So the initial CO2 that's breathed out is lower than the CO2 that is breathed out later. In the presence of bronchospasm, there's an upward slope on the capnograph, and that is the reason for it. And this is a very sensitive way of detecting bronchospasm in a patient. Pulmonary perfusion is never evenly distributed because blood is dense and pulmonary pressure is low. So blood will always go to the most dependent part of the lung. Where that is will depend, of course, on the patient's posture. Pulmonary blood flow volume is only about 10 to 20% of the total blood volume, and yet the entire cardiac output is passing through the pulmonary circulation at about 1/6 of the systemic blood pressure, a typical pulmonary blood pressure being something like 20 to 25 millimeters of mercury over about 7 to 5 diastolic. Essentially, the pulmonary blood pressure is just enough to get the blood to the top of an upright lung. Maldistribution of pulmonary blood flow is the most common cause of hypoxia in pathophysiological states. Resistance to pulmonary blood flow is determined by a combination of the pulmonary artery pressure, the pulmonary venous pressure, and an interaction with the alveolar pressure, because the pressure in the alveolus can cause compression of the capillaries and therefore in itself reduce blood flow through that region of the lungs. And this gives rise to the classic West zones, which are usually considered when you regard an upright lung. And if we look at this diagram, you can see at the top of the lung, the pulmonary alveolar pressure, which is P big A, is greater than both the pulmonary arterial pressure and the pulmonary venous pressure. And therefore there's no blood flow because the pulmonary vasculature is compressed from the outside by the high alveolar pressure. This is a classic Starling resistor. As you move further down the lung, the pulmonary alveolar pressure stays about the same, but the pulmonary arterial pressure increases, and therefore you reach a point where it overcomes the pulmonary alveolar pressure, and so perfusion starts and increases further as you go down the lung. But the amount of perfusion in this area of the lung is still governed by the difference between the arterial and the alveolar pressure, until you get to the point furthest down the lung where the pulmonary venous pressure is now bigger than the pulmonary alveolar pressure. And therefore, this is the much more classic and easier to understand situation where the resistance to flow through the pulmonary capillary is determined by the difference between the pulmonary artery and the pulmonary venous pressure. Those three areas I've described are usually described as West zones 1, 2 and 3. In West zones 1 there's ventilation but no perfusion. In West zone 2 there's increasing perfusion as you go down, so ventilation and perfusion become better and better matched. And in West zone 3 there's constant ventilation and perfusion. There's also, since these were classically described by the respiratory physiology John West, there's also a fourth zone being added even further down the lung, where the interstitial pressure starts to compress the whole lung structure, and that itself starts to cause pulmonary perfusion to drop off again. Hypoxic pulmonary vasoconstriction. This is a fundamental adaptation to redistribute perfusion away from hypoxic areas of the lung. It's a very good thing if it's working regionally. It's a very bad thing if it's global, because it suddenly increases pulmonary vascular resistance and puts an enormous strain on the right ventricle. The exact mechanism of HPV hasn't been fully elucidated, but there is an equation which demonstrates that most of the vasoconstriction is governed by the alveolar partial pressure of oxygen in the area where that pulmonary capillary is perfusing. But there's also a contribution from the PO2 in the pulmonary artery, which is of course the mixed venous PO2. About 2/3 of the contribution comes from the alveolar PO2, and about 1/3 of the contribution comes from the pulmonary arterial PO2, and that's shown in this equation here. The only thing to remember about this, of course, is if the area of the lung that is being perfused is consolidated, there will be no oxygen, there'll be no gas in the alveoli in question, and therefore the entire stimulus for hypoxic pulmonary vasoconstriction is going to come from the mixed venous PO2. What this means is if you improve a patient's mixed venous PO2, you actually will to a certain extent improve their shunt through consolidated lung, because there'll be less stimulus through that area for the pulmonary circulation to constrict. Ventilation in relation to perfusion. This is VQ matching. This is a very important area, and this is probably what is essential to make the lungs work properly. The need to match ventilation and perfusion together. Wasted ventilation to alveoli that are poorly perfused increases the work of breathing unnecessarily, because a larger tidal volume is going to have to be generated in order to overcome this wasted ventilation. Wasted perfusion through areas that are not adequately ventilated will result in unoxygenated or poorly oxygenated blood mixing with the well oxygenated blood, and will cause systemic hypoxemia. Gravity affects both ventilation and perfusion. It affects ventilation because the weight of the lung starts to compress the lower part of the lungs, whereas the upper part is relatively distended. So each part of the lung is on a slightly different part of the compliance curve. Therefore, the top of the lung is not as well ventilated as the lower part of the lung. Perfusion varies with posture because blood is heavy and the pressure within the pulmonary vasculature is low, and it's only just sufficient to perfuse the top of the upright lung. So perfusion increases as you move down the lung towards the dependent parts. The effects of gravity on perfusion is much greater than the effects of gravity on ventilation. What this means is that the upper part of the lung is relatively well ventilated relative to the perfusion, and the lower part is the other way round. These are often described by what are known as VQ ratios, where V is the ventilation and Q is the perfusion. Both the units for ventilation and perfusion are flow units, usually litres per minute, so VQ ratios per se have no units themselves. Considering the lung globally, normal alveolar ventilation is about 4 litres per minute. Normal perfusion, cardiac output in other words, is about 5 litres per minute. So the normal VQ ratio for the whole lung is 0.8 at rest. However, this disguises the regional distribution of VQ ratios throughout the whole lung. Consider the top of the lung, which is relatively well ventilated and poorly perfused, so V over Q is going to be higher. It's going to move towards infinity if there's no perfusion at all but ventilation is maintained. Whereas moving down to areas of the lung that aren't ventilated but are perfused, then V is 0, and so whatever the value of perfusion, the VQ ratio is going to be 0. And it can take up any value in between those extremes. Regionally, small areas of abnormal VQ ratio are adjusted for essentially by hypoxic pulmonary vasoconstriction, because remember, abnormal distribution of perfusion is the commonest cause of hypoxemia, so hypoxic pulmonary vasoconstriction is the fundamental mechanism to help ameliorate this. Physiological shunt is describing the equivalent amount of mixed venous blood that would have to be mixed with fully oxygenated end pulmonary capillary blood to produce the level of arterial oxygenation that is observed in the patient. It's made up of a number of components. The most important component are areas of low VQ ratio. In other words, areas that are poorly ventilated but well perfused, so they don't get oxygenated as well as would be normal. There's also anatomical shunting of blood from systemic veins to systemic arteries. This is through both Thebesian veins in the myocardium and bronchial veins draining directly into the systemic circulation. On top of that, in pathophysiological settings, you can have abnormal shunting. The clearest and most obvious example would be anatomical shunting due to congenital heart disease. More common are the reversible causes of shunting due to pulmonary pathophysiology, such as infection and consolidation, pulmonary edema, pulmonary collapse, neoplasms, pulmonary emboli, be they thromboemboli or gas emboli, or arteriovenous shunts within the pulmonary circulation itself. The shunt equation calculates the proportion of mixed venous blood that would have to be mixed with pulmonary end capillary blood in order to generate the partial pressure of oxygen that's observed in the patient's arterial circulation. It's a theoretical amount because the majority of blood that causes a fall in arterial oxygenation below that seen in the ideally ventilated and perfused alveoli is actually blood that's passing through areas that are poorly ventilated, in other words, low VQ ratios, rather than areas that are truly shunted where the ventilation is zero. However, it's a useful calculation. It gives some idea of how severe pulmonary perfusion mismatching with ventilation is. So what the shunt calculates is usually expressed as QS over QT. That is the shunted blood flow over the total blood flow. So it's a proportional calculation. On the right hand side of the equation is a ratio of two quantities. On the top of the equation is the amount of oxygen in the end capillary pulmonary veins subtracted from the amount of oxygen in the systemic arteries, and that's divided by, again, the amount of oxygen in the end capillary pulmonary veins minus the amount of oxygen in the mixed venous blood. Okay, there's some fairly common traps when you're trying to talk about the shunt equation that it's important to understand. The first is the left-hand side of the equation is the amount of shunt over the total cardiac output. So it has to be less than 1, and it also has to be positive. Therefore, when you're trying to remember which way to put up the right-hand side of the equation, the important thing is that you need to put the small number on the top and the big number on the bottom. On the right-hand side of the equation, the first expression on the top and the bottom has to be the number that's got the biggest value. And basically the most oxygen you're going to find is going to be in the end capillary pulmonary blood. So that's what goes on both parts of the top and bottom of the equation at the beginning. And then you've got to get a smaller number on the top, so of the two numbers that you're left with, which is the arterial and the venous oxygen content, you need to subtract the arterial oxygen content on the top to give you a smaller number than you get on the bottom where you subtract the mixed venous oxygen content. Now that sounds a bit long-winded, but actually if you work your way through that, it's quite an easy way to remember which way round the shunt equation goes. The second important point is the equation requires oxygen content and not oxygen partial pressure. This is a very common mistake. They are not linearly related, as you know, because the oxygen content against partial pressure generates the classic hemoglobin dissociation curve, which is sigmoid shaped. So in some way, the oxygen content needs to be either measured or calculated. So how do you get the oxygen content of the three different bits of the blood circulation that you require? The arterial is the easiest. You simply take an arterial blood sample, and then you can either calculate it from the PO2 or calculate it from the saturation, ideally from the saturation, because if you're going to calculate it from the PO2, you need to make a lot of assumptions about the P50 of the hemoglobin dissociation curve. To get the mixed venous oxygen content, you need to sample mixed venous blood, and there are only two places in the body you can get that, and that's either the right ventricle or the pulmonary artery. It's no good taking it from the vena cava because it's going to be different coming from the superior and inferior vena cava. It's also no use taking it from the right atrium because the coronary sinus drains into the bottom of the right atrium and the blood's not properly mixed till it gets into the right ventricle. And the oxygen consumption of the myocardium in somebody at rest has a major impact on your mixed venous oxygen content. What you can't actually sample and measure is end capillary oxygen content, and this can come up as a question, and this does have to be calculated. It's calculated by assuming that the end capillary partial pressure of oxygen is the same as the alveolar partial pressure, and substituting that into the oxygen content equation using assumptions for the P50 of the hemoglobin dissociation curve. So I hope you found this useful, that you can go through it and pick out the bits that you find more difficult and cover them again and find the explanations useful. We've talked about compliance, we've talked about the work of breathing, we've talked about ventilation and perfusion distribution and how they're matched and mismatched, and we described the shunt equation, all of which are important subjects for you to understand as you go forward to the primary fellowship. And I wish you the very best of luck.